Basically, in this chapter, we're going to discuss some common intraoperative routines, basically prepping and planning for a case. We're going to learn how to go over some common protocols that we use in surgical techniques, how the elements of a case come together, what kind of action plans we put together for surgery, how we group certain surgical objectives into types like counts and timeouts and so forth, and then just the purpose of all the preoperative case preparation in general. The purpose of case planning is to orient the surgical technologist to the flow of the surgical procedure. Usually the circulator and the scrub, they will work together to prepare for an assigned case. Once they're assigned to a room, they're assigned a case. They have to look at all of the fundamentals of preoperative and intraoperative preparation, all the tasks that are involved as far as getting things ready, getting the surgeon's preferences in order and in line to have a successful surgery. The tasks are always going to vary depending on the facility, the setting, and the scope of practice. So just remember, not every clinical site that you attend will always be the same. You'll learn different things that one clinical site does that maybe another clinical site doesn't do. But overall, in general, the basics are always the same. It's very important that you study these terms and understand them. Obviously, we know when we amputate something, it's removing something. You're amputating it. It's usually going to be a finger, like a digit, a limb, a leg, and so forth. Not very common do we do hand or arm amputations unless it's something caused by trauma, like regarding an injury at work with a machine or a car accident and so forth. Anastomose or anastomosis, this is a joining of two hollow structures. Usually we anastomose arteries, veins, the intestine. So it's bringing two hollow structures together and anastomosing them. If we approximate something, we bring it together. This term is used a lot on skin stapling. So we approximate skin edges. We will bring them together and then fire the stapler as we are stapling. Blunt dissection, this is where you want to go in and you want to dissect bluntly without causing any injury. So a lot of times when we separate these tissues, we don't use sharp instruments for the blunt dissections. They often will use their fingers, sponge sticks, and so forth like that to get in there. Kittners or peanuts or those types of equipment to get in there to dissect. We do this a lot, like with hernia defects, inguinal hernias, to reduce the hernia and get down to the hernia sac. They will do a lot of blunt dissection. If we debride something, you're going to cut away dead tissue and remove it. And then sometimes when we're closing, especially like legs, amputated legs, the stump, when you're closing it, often you will get what we call a dog ear. This is where the skin edges will pucker out of the sides due to poor suture placement or not proper alignment. And then they have to go in and remove those dog ears and bring the skin edges back together to put new stitches in. Debulking, debulk. This is a common term used to remove a large portion of a tumor. If you do bulk it, you don't remove the entire tumor. These would be like maybe on a pancreas, or if it's in an area where it can't be removed for the patient to be able to survive, the brain, sometimes the lungs and stuff like that. So they'll remove a large portion, but not all of it. Obviously, if we dissect, we're going to separate structures. If we elevate, we rise, we lift. Excise means to remove it. If you excise it, if you can relate back to medical terminology, that means to remove tissue, and you have to use some type of instrument to remove it, such as a scalpel or a bovie or scissors or curved Mayo scissors and so forth. Exposure, we need to see, right? Surgeons often need exposure. They need to see what they're working on, so this is a common term we use as well. If we want to exteriorize something, you want to bring it somewhat outside of the body so you can see what's going on. A lot of times we do this in open bowel procedures. we'll run the bowel outside of the body and look for certain issues to see if we can figure out if it's an unknown cause as to why the patient's having pain and so forth. Ligate means to tie two vessels together usually, or tie something. You constrict it, so you'll tie it. We often use reels for this, or suture ties on a passer on an instrument, and I'll show you that in lab so you'll be familiar with it. Resecting means you want to remove a large portion or segment of the tissue. If you resect something, often we resect bowel, so bowel resection would be a common procedure that you see up on the schedule or so forth. Undermining it means that you go underneath and separate one flat tissue from another. If we want to undermine and just go right underneath the sub-Q, we can undermine it using scissors, fingers, sponges, and so forth. And obviously visualization, you want to be able to see everything in full effect. If you can visualize or do direct visualization, you'll need no magnification, so no extra assistance with viewing. Obviously, case planning, definitely not mandatory as the slide states. It's simply good practice. You definitely want to always have a plan. Think about what you need to do to make the case run efficiently. Anytime you're made aware there's communication that happens prior to a case that's pertinent to the case, you need to plan around it and make sure that you have everything you need in order for it to run smoothly. Get the patient in efficiently, work on them, and get them out as safely as possible. So it's not mandatory, it's just simply good practice. As a surgical technologist, you're going to learn how to organize, your back table and open supplies in a manner or in a way, which is kind of what you're learning right now in the lab. So there's always a logical sequence as to why you want to, do your plans the way, or put your plans into motion or action the way you want to in order to make it run efficiently. Case planning and case management, they're not the same thing. If you're planning, that's pre-operative. It's before the patient's coming back. It's the pre-operative stage. What do we need? Do we need to put attachments on the bed? Do we need to put extensions on the bed? Do we need to put the head of the bring the head down to the foot? Do we need to have an extra table in there for a large instrument set if we need to open it later? Should we bring any additional sutures that are not already in the room that you can pull from that the surgeon likes? Or if maybe there was a discussion prior and you were working with the surgeon in another case and he gave you some direction or some instructions as to what he wanted to follow with the next case. So you're always planning pre-operatively, okay? Case management is managing the case. This is intraoperatively, so it's the case throughout the whole case. How are you managing that case in order for it to run smoothly? So those are kind of important to know the difference. If you're a student, obviously, if you can critically think and case plan and come up with solutions or ideas or things you need to get, from the workroom and so forth to make your case run smoother, it's definitely going to make you stand out, especially make you advance more quickly in your career and be somebody who might be eligible for employment before even graduating from this program. Obviously, when we look at elements of a case plan, there's certain things to just kind of remember. It can't always rely on preferences. There could be a generic card, but a lot of times the actual card itself isn't as specific as you need to know. Things happen with patients. They have different needs, so it may not always be specific to that special patient's needs or the type of procedure you're doing. So obviously the elements are always going to be these simple bullet points, the name of the operative procedure, the type of the procedure, what's the diagnosis, what were the lab findings, what's their weight, what's their age, what types of mobility problems do they have, sensory deficits, position, and incision of an entry site. So how are we going to position them to gain entry into the wound? We'll also look at skin prepping, draping, what instruments are needed. Do we need C-arm in the room? We need to call them ahead so they can bring their equipment in and get it ready to go. Are we doing a case where we need pneumatic air, or we need a pneumatic tourniquet, electrical devices, certain types of equipment that we need to bring in the room? If there's implants being used, have we ordered them? What types are they? Are they ready to go in the room? Are there trials and so forth? What are the specific sutures and staples that are going to be used? Are we working on a bowel, so we're going to need GIA staplers? Will the surgeon want drains? Obviously, if it's a thoracic procedure, you know you're going to need chest tubes, so you need to have those ready to go in the room. What types of dressings are we going to use? If it's on a female and you're doing an OBGYN case, you might place a peri pad. We might also use stabilizers to keep hips and shoulders in place after we've done something and worked on those types of bones. So there's lots of different things available that are specific to the wound as far as dressing goes, and how that's going to affect making sure we dress them properly at the end of the case. Also, what's the patient's destination after surgery? Are we taking them to recovery, PACU? Are we taking them to ICU? Are they leaving? Will they be discharged? If it's in a same-day surgery, they can't stay over 23 hours in order for insurance to pay for it. So they'll probably be discharged. They'll go over in their little PACU bay for 1 or 2 hours, let the drugs wear off, make sure everything's okay, and then they'll get to go home for the day. So these are important things that we need to understand when we're prepping for a case. When we look at categories, when we're categorizing surgical cases, basically we look at knowledge of the procedure, what types of surgical techniques are going to be required, like what types of room is it going to go in, is it going to need diagnostics, and so forth. Are we going to need to put scopes in and look at things to assess the patient and diagnose them to be able to treat them while they're in there and so forth. So obviously for diagnostics, some of the things we look at is what is the main structure of tissue we're working on, what procedure will we perform for the diagnosis, will tissue samples need to be taken, so that means we'll have to do possibly biopsies and so forth. If that's the case, what are we going to do if we need to do implants? Okay, so for reconstructive or implant surgery, what specialty instruments will be used? I kind of mentioned that on the previous slide. When we're looking at the patient's age, do we need to, if they're elderly or if they're a pediatric patient, do we need to turn the heat up, the room up, the temperature prior to the patient coming back? So there's just lots of things that we need to look at. If we look at wounds and contaminated wounds, well, you need to have 2 separate setups to keep all your clean stuff with your clean stuff, and when you get into the contaminated part, and keep all your dirty instruments together. Obviously, if it's dirty in the beginning of the case, you'll use dirty, but then when you go to close it, you definitely don't want to use dirty instruments while you're closing the wound, because the chances of that incision becoming infected greatly increase if you do so. So those are just things to think about. How many specimens, if we do take specimens? Will we need culture tubes? Will we need specimen cups? Will we need TELFAs for biopsies? What do we need to separate the specimens, and what will we be sending them in? So this slide just basically walks you through, if we're removing tissue, organs, foreign bodies, how will we plan to do so? So what will be removed, what type of tissue? I mentioned that earlier. What's the approach to get to the tissue? What specimens will be taken for frozen section analysis? Have we already contacted the pathologist to let them know? Is the wound contaminated? If so, do we need to do cultures to be able to treat them with antibiotics? And what special procedures need to be followed to submit forensic items removed from the patient? So if it's a foreign body and so forth, what are the forensics that we need to, what are the forensic items that are being removed? What protocols are there that we need to follow to make sure that we don't break protocol, basically, is what it's saying. This reviewing the surgeon's preference card. So basically, in the morning at report, you'll report first thing. You'll get a surgery schedule, and you'll know what room you're assigned to. Some places they let you know like the night before. When you leave, you can look at the surgery schedule to see what room you're assigned to. But basically, every case that you do is going to have a preference card on the case cart. And so this preference card basically is an electronic document or paper form that has specific supplies and methods used by each surgeon for cases he or she performs in the facility. So what you're going to find on it basically is instruments, any special equipment. For example, if it was a broken bone, we may use a tourniquet. So we might apply tourniquet. So we would need a tourniquet machine in there. The actual tourniquet itself and the web roll padding we place before we put the tourniquet on the skin so it doesn't cut the skin. It's always going to have their glove and gown sizes, what their preferences are for skin prep, like the boundaries, how far they want you to go, and so forth. And then their draping techniques sometimes are on there, what medications they like to use. The idiosyncrasies, like the things that are pertinent for them, the things they like, it might be on there. Don't do this. Surgeon doesn't like this. Surgeon prefers this kind of sort of thing. Assembling supplies and instruments. Sometimes for the scrub, they'll have notes and it'll have steps as to help you set up things in a specific order, or if it's a specific equipment and it's not something that people commonly use, the steps might be on there for you. I've seen scrubs actually tape the preference sheet with the notes on the wall behind their back table, so when they're setting up, they can look at the preference sheet to help them. So basically, the preference card, it helps you to have everything ready. It prevents delays. It helps cut cost, right? Because if we don't open everything that's sent up, then we're saving the patient money. You only open what it says on the preference sheet to open. And not just guess at how many sutures you think they're going to use. So usually it gives you an idea of what to open. It also helps with communication, team effort, and so forth. And you're going to kind of learn that there's a method for gathering supplies. So we call it the case cart method. So that's important to know. There's always a method for gathering supplies, and we call it the case cart method. So basically all the supplies come up on a case cart. They're inside it, on top of it. And so that's the method we use for picking or pulling a case. The cases, after they're picked and ready to go, they're usually kept in the substerile areas to protect them from contamination. They help, having case carts help reduce turnover time because all the supplies are picked, so you don't have to run and pick them prior to the case. They're already ready to go, hopefully, unless it's an emergency. And most of your facilities that do emergency cases have 2 or 3 emergency carts always ready to go in the workroom, so you can run and grab them, like for a bowel or for a chest procedure or a craniotomy. Those types of carts are already pulled and picked. Night shift usually is the one that sets around the rooms, gets things ready for the first case of the day if they have time and they're not in a room working all night, if it's a facility that does third shift. If not, first and second shift usually will start picking case carts and getting them ready and send those up for the first cases of the days. Actually, they pick the majority of the cases throughout the day, so there's a scheduled time allotment. And so let's say they might have the first 2 cases picked for that room, and then somebody else would pick the third case and so forth. They always have it ready at least 30 minutes, if not an hour, before a case is scheduled to start. So when we're preparing non-sterile equipment, that just means bringing all this non-sterile equipment in the room. You definitely, as a scrub, will share a responsibility with the circulator and getting the room ready for, the case, whatever you're planning for. So there's some essentials that this bullet point or this slide list that are under these bullet points. The first one is always arranging the furniture to line up with, sorry if you hear that, that's my dogs, they're wrestling right now, I apologize. That's always arranging the furniture, like where are we going to position the OR table? You usually want it under the lights to begin with. What side of the room, if the C-arm's coming in, what side are they going to be on? So where do you want your tables and things like that? Do you want your Bovie machine and your suction at the head of the bed or at the foot of the bed? Are you going to be using a tower? Just remember that when we're preparing, we always need to think about about preventing any form of contamination. So if something's sterile, it should always at least be 12 inches, but the golden rule is 18 inches from non-sterile areas. You know, we need to put clean linens on the bed before the patient lays on it. And just things like that. You know, what are the diagnostic materials? So when I talk about diagnostics, that's gathering. That's kind of important to know. It's gathering like your diagnostic studies. So how they have x-rays or MRIs done prior to this. So we usually pull them up on a PACS system or whatever you use in order to view those in the case. You want to have those readily available so they can look at the data or know if they're in the right spot during the case or what they're trying to fix and so forth. Obviously, like power sources for powered instruments. So you definitely want to know, you know, what's going on. You want to make sure that all your gas cylinders that you're using are at least 50% full so you don't run out of the gases during the case and so forth. Make sure your cords work, plug them in, make sure the equipment turns on. It's kind of embarrassing and doesn't go over well if you go to use a piece of equipment and it won't even power up because you didn't test it prior to the case starting. So just things to be aware of that are really important to making a case run smoothly. So obviously some recommendations for case opening. You guys are being taught this in the lab. Usually when we open, sterile supplies should be open as close to their time of use as possible. So prior to the case starting, usually 30 minutes to, like, we'll send for the patient 30 minutes before the case is supposed to start, and that's when we'll start opening. So it can be 30 to 60 minutes depending on the time of surgery is supposed to start. So, but these are just some recommendations, you know. So we always want to monitor the room after we open it to keep things from happening as far as contamination. A fly or something could come into the room. I think I've told you that story that happened to me. So when we look at these recommendations, obviously you want to maintain a safe distance from the sterile surface. You know that. So when you open things and you're not sterile, remember to walk out, stay away from things. You always want to place your trash in the appropriate receptacle. So don't throw saturated blood in a white plastic bag, put it in the biohazard. Throw the linens in the linen bags. So make sure you get rid of all your soiled stuff and put it in the appropriate receptacle. So when you open it, when you're opening the back table pack, you're going to break the seal tape, and that goes for any of the sterile supplies. It's always sealed with some type of tape. That's usually the white backing on it, or you know, just open it up. You want to pull the items from the inner wrapper, which is the plastic wrap, aseptically, and then it's usually in the blue envelope wrap. So you're going to place all your heavy items on a small table. And you always separate heavy from delicate items. There's definitely got to be some separation there. If you open instrument containers, you want to open them like we've taught you aseptically. Definitely don't hold items not necessary for the procedure. So that means, you know, you want to make sure that you only open things as they're needed. For example, implants. You only open those when the surgeon asks for them. You don't open those prior to the case, because what if they get in there and something's not right and they can't use that implant? Same thing with like mesh and so forth. You always hold until the surgeon asks for it. You will be opening sharps during the setup. And it talks about never gowning and gloving from the back table. That's just good protocol. That's why we're teaching you to open and gown and glove. Open your gown on the Mayo stand. And you can glove from the back table, that's fine, but at your facilities, a lot of them may have you gown and glove from that Mayo stand and not the back table. So just know that supplies are always open in sequence from large to small. It avoids pyramiding of supplies, like stacking. So that's why we have you open the back table first. It's the biggest area, right? And so what you're doing is you're always increasing your sterile area. The more you increase it, the less risk you have for contamination. If you do have to stack or pyramid supplies, you always put the heaviest ones on the bottom, okay? So make sure you put those on the bottom. So just know your basic pack's always going to contain the towels, the drapes, the gowns. It's always centered on the back table, and it's always open using aseptic technique. Some of you are struggling with how to open it with one person versus how to open it with two people. And so we can talk a little bit more about that in the lab next week, but just make sure that you understand that the method to open it with 2 people is different than the method to open it with one person. When we talk about receiving the patient, so when the patient comes to intra-op or comes into admissions, or they're getting ready to come back to the operating room, obviously the circulator has specific duties, and so does the anesthesiologist, to prep for this patient coming back. You know, for anesthesiologists, you'll need the drug box or pull up their chart. They'll look at any medical history and complications so they know what drugs they can have in the room and use and so forth. Once the patient comes in the room, the circulator's duties. So obviously the anesthesiologist and circulator will talk to the patient prior to coming back to the OR. The circulator usually is the one that goes and gets the patient and brings them back into the OR, and they introduce them as they're coming in the room. And so when they get in there and we get them moved over, they will hook up the blood pressure cuff, EKG leads. They'll put on the sequential stockings a lot of times, get them a warming blanket, place the bear hugger on them. And then during intubation, they're the ones that help with cricoid pressure and assist putting the stylet in the ET tube and so forth as the anesthesiologist is putting the patient to sleep. And then obviously once the patient goes to sleep, then positioning begins and we get them ready for prepping and then for the surgical case. These next few slides are going to go over intraoperative sequence, basically the sterile setup, the things that you've been practicing in the lab. It's just going to kind of lay it out for you and give you recommendations and basically a methodical method for why we do things the way we do to improve efficiency and greatly decrease stress and errors in the learning phase. So obviously in the intraoperative sequence, you know, obviously immediately after performing your hand asepsis, whether it's the wet scrub or the foam or the Avogard, after you perform that, you gown and glove, you have to organize your sterile back table, which is what you've been working on in the lab. After you organize the back table, the Mayo stand, and any other instrument tables, you'll do it in that order, and this is basically called the sterile setup or setting up this case. Excuse me. The sterile setup takes place near the time when the patient arrives in the operating room. A lot of times this process is definitely going to be overwhelming for you as a new scrub or a student. So that's why we're teaching you to do things methodically and in a method to improve efficiency, to make it look as though you understand the concepts and you know what you're doing. So the scrub, you're going to gown, glove, and immediately start setting up. After you set up and everything is laid out and you have everything, you know, in order, in the fashion as to which it should be, you're going to do your first count, which is kind of what we've showed you in the lab. The first count is always known as the initial count. It's counting all the instruments and supplies you have ready prior to the start of the case. After you do your first count, basically general anesthesia is going to be initiated. That means the patient's in the room. You should usually count before the patient's in the room so they're not awake and listening to you count, because the circulator is going to be busy doing other things. And obviously we know the scrub and the circulator perform the count. So it's just good protocol if you scrub in early enough, if you have to count instruments, to count prior to the circulator going to get the patient to bring them back to the room. Then general anesthesia is initiated. And then if there's any additional supplies that you forgot after the patient goes to sleep, the circulator can open these additional and distribute any additional supplies that you need. The patient's asleep. All your sterile tables are moved into position around the patient, and this would be after you've draped the patient. So you move your tables around into position. You throw off your suction tubing, ESU tubing. All your sponges are laid out, and then after everything looks ready to go, that's when we're going to do the universal timeout. Okay, the timeout is very important. Just remember, when you're setting up, you don't want to move things around aimlessly. If you touch it, place it where it goes. Movement increases risk of infection. So I've kind of been talking to a little bit of you about this as we've started to progress in lab. Some of you will touch something, lay it down, touch it, lay it down, touch it, lay it down. A fine example is your glove wrapper, right? You want to wad it up and turn around and throw it away. Well, just leave it on your table and then you can throw it away later after you've set up. So the less movement, the less risk of infection. One of the things I forgot to mention on the previous slide is that when I talked about making sure that you don't move things around aimlessly, you also want to increase the size of your sterile fill to keep from contamination as well. So increasing the size of the sterile working area is always good protocol to decrease stress and increase efficiency. So before organizing and preparing supplies, you always want to increase the size of the sterile area. You do this is important to know, and you do this by not only opening your back table and working off that, but by draping the Mayo stand or any other additional areas that tables that might be draped to put your instruments and other supplies on as well. Obviously, the intraoperative sequence is as follows. Once we have done the universal timeout, then the surgery will be, the surgeon will ask for the scalpel, and as they're making incision, that time is noted as the surgery begin time or the start time. During the case, the scribe will anticipate the surgeon's needs, proper equipment, things, and so forth as to give to the surgeon as the case is progressing and moving along. And then you're going to perform your counts throughout the case per protocol. Depending on what type of procedure and what kind of counts you have to perform are going to dictate how many counts you'll perform during the case. Also, specimens may be collected at that time or any time. You just always want to verify with the surgeon that it's okay to pass off the specimen before you do it. And sometimes it's best to ask again the name of the specimen so it can be labeled properly. Then the wound's closed. As the wound's being closed, it may be being closed in layers. It may be a fast closure, but usually as the wound is being closed, that's when you're going to perform counts as well. And then once the patient is closed, anesthesia will reverse the drugs that were given so the patient can hopefully wake up as soon as we remove the drapes, and we can get them out into recovery as soon as possible. As the anesthesia is being reversed and we've closed the wound, then often we apply dressings. And again, dressings are going to be applied depending on what type of wound it is. You'll have special dressings for that. And then the drapes are removed, and then the patient is stabilized and transported to recovery. So just remember, using a methodical approach to all setups improves efficiency and greatly reduces stress. So basically, this slide talks about a typical sequence of steps that you should follow in the preliminary stages of a case cart or planning for your intraoperative setup. Obviously, there's priority preparation. So when you scrub in, right, we're teaching you this, you always want to get your towels, gowns, and gloves and drapes organized in the corner. And you want to organize them in the order of use, right? So your drape will be on the bottom, then you'll have your 4 blue towels on top of it or whatever you're using to towel off or square off the surgical site. And then you'll have the surgeon's gowns, then their glove, and maybe a towel on top of their gown to dry off with. Because, right, that's the order. They walk in with wet hands, they dry, then you have to gown them, then you have to place their gloves. Then you turn them, and then you guys will drape the patient. So that's kind of how that works. Obviously, your light handle, suction tubing, ESU pencil, and holster, all that needs to be set up. It's part of the count, so you want to organize it so when you count it, like we're teaching you, the circulator can visualize it during the count. So definitely make sure you have all of that together. You also can keep all of that equipment in a dry instrument basin to the side or on the Mayo stand, and we're teaching you to do it on your Mayo stand. After you've got your Mayo stand ready to go, we have you lay it on top, because again, once you push that Mayo stand over the draped patient, the surgeon's going to start grabbing those light handles and helping you throw things off so you can get ready. Typically, you throw all that stuff off, put the light handles on, and so forth before you do your timeout. Because when you do your timeout, everybody comes to a standstill and you have to be quiet. That's just, JCAHO requires that process to happen that way. So then obviously on your Mayo stand, you're going to have your starting instruments, the instruments that are most commonly used in the case, your sponges, sutures, and sharps. Those will also be part of the counts, but they can be on your back table or on your Mayo stand depending on where you need them. But obviously, they are priority instrumentation. And then you need to make sure you have all the priority equipment you need to start the case. And then so after that, all the other stuff you use is called secondary preparation. So Definitely a typical sequence. You want to pull all your gowns out from the pile, stack them in order for use, top down, prepare the light handle, suction, ESU pencil, holster, and all your starting instruments. Mostly your starting instruments is your scalpel blades, scissors, clamps, shallow retractors. If you're using a suture, you would lay your suture up there or suture ties, and I'll show you how that works if you have suture ties and how you can get them ready and organize them on your back table or Mayo stand. So again, you just want to make sure that you organize it by type so that when you're ready to count with the circulator and she's or he is free to do so, they'll be able to look and verify the packets and the sharps that you're counting. So it's important to know the difference between priority and secondary equipment when dealing with emergency surgical patients as well. I keep talking about suture ties, free ties, and you wouldn't know this yet, but I'll bring some into the lab tomorrow so you can see what free ties are and ties on the passers are. Ties, obviously, you want to take them out of the package. Some of your ties come in suture package. It looks like an actual suture package. It's just a bunch of ties. A lot of times you will place those out in the folds of towels. You'll see that on page 413 if you look in your book. We create what we call a suture book, and we separate the sizes of the ties, and then we will fold the blue towel over it, which is what the suture book is, and have those ready to go on a passer. Your tonsil Adson Schnitt forceps are good to be used for a tie on a passer. Sometimes we use Cryles and Kellys and so forth as well, if you're doing a tie on a passer. We also have reels, and I'll show you what a reel looks like. It looks like a little wheel, and it's got suture material in it, so you can spin it off the wheel and cut it as you're using it to tie off vessels and so forth. Reels should always be placed on the Mayo stand for quick access. Obviously, if you're doing swaged needles, if you're doing a needle uh, suture passer, basically it's just loading a needle on a needle holder and using it that way. And then sometimes these things can be placed in a small basin or on the back table. It just depends. When we're talking about suture too, there are some different types of suture you're not aware yet. Again, it's going to be very unfamiliar to you for a long time until you've been doing this for a while. But there are sutures that we have that are called CR sutures, which are controlled release. And on the packet, they'll say CR on them, and those are pop-offs. And so anytime we're in an emergency situation, we use a lot of pop-off sutures so we can run the suture through, the needle through with the suture material and pop that needle off and hand it back to the scrub. And it's just repetition. You do it and do it and do it, and you might tie off later. So again, you want to place the controlled release or pop-off sutures in an easy accessible area. So obviously practice, 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 practice. The more you practice this, the more you'll get familiar with it. So you won't get exposure until you get to the clinical sites. When we're talking about surgical instrumentations, just know during your first few rotations at clinicals, you won't know what is expected to use or be very good at anticipation. So don't sweat this. But when we look at surgical instrumentation, these are some of the bullet points that we want to focus on. You obviously need to have your instruments and supplies arranged in the order of use. You need to think about what you need. Obviously, setups are going to vary depending on who your preceptor is, the clinical site you're working at, what surgeon's preferences are, and so forth. You will always place your instruments in a specific place. So when you start setting up and doing it your way, do it that way every time. Obviously, Lana, Lacey, and I have been teaching you to do it the ways that we like. And there's a reason for that because we've been doing it for a long time and we find that those ways work best. So there's no wrong way to do it, but however you do it that way every time. You always go in with a setup, you have an action plan in place, and you follow it. You need to think about the plan and follow through with it and doing it that way every time. And you'll do that for every case. The only variations is the different instrumentation that you use, the different drapings you use, but setting it up is always the same variance, okay? Again, if you're stacking trays, you always place the heaviest tray on the bottom so it doesn't crush the delicate, more flimsier instruments and so forth. So you always put the heavier tray on the bottom. You definitely will rely on your preference sheet. You'll rely on your preceptor. You're going to be thinking about what the surgeon is doing at all times. You're going to be learning how they suture, how they tie, what you should have in your hand next. So if they're suturing, right, you need to have suture scissors in your hands next. If they use the Bovie and they're going in the abdominal cavity, sometimes then they'll have a retractor put in place so they can visualize once they get through the peritoneum. You just have to be thinking about what to do next. We usually say that it's always good to have something in your hand, even if it's not the right thing. It just looks like you're trying to stay one step ahead of the surgeon. So that always looks really good. And so when suturing, or if they're doing the clamp cut tie method, it's always like hemostat, mets, then tie it off, okay? And then whatever they use to tie it off with, you would hand them the suture scissors. So we'll go over that a little bit more in class. Just remember when setting up your Mayo stand, again, this is for the most frequently needed instruments, especially at the beginning of the case. You definitely will standardize your setup, and it may just change during individual facilities, like I mentioned, or whoever your preceptor is or whoever the surgeon is. But just always remember to keep your Mayo neat and clean. It's very important that you have it organized. You will develop OCD in this profession if you already don't have it. I promise you that. Medications and irrigation solutions are usually distributed after a case is underway, or usually just before a case begins, but definitely only when the scrub is present to receive them. So you definitely never put solutions on the field unless the scrub is scrubbed in and ready to receive them. So irrigation, it's always distributed after the start of the case most of the time. You always want to label, right? All irrigation fluid should be labeled. And also throughout the case, any irrigation fluid that's used often is measured by the scrub and recorded. So total blood loss is accurately recorded. So it's important that you write down how much irrigation, or obviously like in our basin sets and our graduated pitchers and things like that, they're calibrated or have measurements on them. So you can know, like if you threw out 1,000 milliliters of saline or sterile water on your back table and you have 300 left, right? So you've used 700, but the Neptune or something that's counting blood loss reads 2,200 or something like that, then the patient's lost a significant amount of blood. And yes, that's a really high number. That would probably not happen. So but it's just at the end of the case, they always record how much blood loss was lost. So it's important too that if you have a slush or a basin or solution warmer, that you label whatever solution is in the basin or the solution warmer as well. If you use a basin, remember it can be on a single or double ring stand, which you've been seeing those in the operating room in our labs. It's important too that not only that we measure irrigation, but we definitely know that whatever we are using, we properly know how to read it for proper measurements and stuff like that. So if you use a Neptune, you need to understand how it reads such volume and what's blood loss, and you always want to clear it out before the start of a case so it reads 0, so you don't have, if you've used it on 3 or 4 cases, you don't have the incorrect amount of how much fluid or blood loss was happened during that actual surgical case. So you definitely need to be aware of how to use all that. So when we're completing setups, again, this is just when you're organizing the remaining of the supplies to complete the setup. This is towards the end of it. Again, you always want to count your sharp sponges and instruments. Once the setup's complete, you don't want to keep handling your instruments again. Less handling reduces the risk of contamination. So after the setup's completed, supplies should not be handled until after the case starts. The surgical tech should remain in the room the whole time. You may break to assist the circulator, but you really shouldn't leave the room unless absolutely necessary. And so that's going to vary on clinical sites. Some facilities may let you break and leave the room. I wouldn't recommend it. As a student, I would never do it. But again, every facility is different, and their protocols are different, and their policies are different. So purpose of counts, obviously we don't want to leave anything left in the patient. As you know, any retained items, basically that are included in a surgical count can be left in the patient. So these retained items are usually soft goods, sharps, any instruments. Believe it or not, instruments have been left in patients before, and miscellaneous small items. So retained items can cause injury, infection. They can perforate an organ. They can lead to scarring. They can have the patient come back to be removed a second time, so repeat surgery may happen. So again, you need to make sure that you understand what your healthcare facilities policies are regarding counts and what you need to do. Retained items is grounds for negligence. It can cause, there to be a lawsuit that takes place. So you definitely don't ever want to leave anything in the patient. And I mentioned on the last slide soft goods, but we talk about soft goods and as you're doing your counts right now as you're practicing in the lab. But your soft goods are all of your sponges like umbilical tape, bustle loops, suture boots, Kittners, dissectors, suture reels, that tip polisher, scratch pad, anti-fog solution. Those are like soft goods. So all of your sponges, all of your suture, we consider those to be soft goods. However, suture does fall under sharps. So I would, some facilities vary on that, so I would just know your soft goods as your sponges and umbilical tape and things like that. Obviously, your sharps are going to be your suture and your blades, your Bovie tip, and so forth. And then again, instruments, and then your miscellaneous small items. Just know anything can be left in a surgical wound, so that's why mostly everything is included in the count. That's another reason why we've kind of been counting. So whose responsibility for the count? Who is responsible? All team members are responsible for the counts. No items should be left in a patient. However, the circulator and the surgical technologist perform the count together. So a circulator will always ensure the correct count and record information in the operative report and the chart. And then the surg tech should know where all their counted items are throughout the case. If you add things, if you drop something on the floor, you always have to be speaking and communicating and letting them know so they can subtract it from the count and so forth. Definitely, if there is an incorrect count, action is taken to resolve the incorrect count, and it's the entire team's responsibility. So you should always know at all times how many sponges, instruments, and other items are inside the patient during the case. Will that happen every time? No. In emergency situations, sometimes you turn to grab something and the surgeon grabs something off your Mayo. If they are nice, they'll say, hey, I'm packing a lap sponge in the belly right now. But again, if you have 3 up on your Mayo and you turn to grab a supply and you look back and you only have 1 on your Mayo, you know they've put 2 somewhere. So you need to quietly in your head be thinking about what's going on and where these lap sponges are going and so forth, so we don't lose anything and leave it behind in the patient. That's why it's important you always count sponges before you at least close the abdominal, the peritoneal cavity, because if you don't want to have to open it back up if you've left a sponge in the patient. First thing is when you're performing counts, you always want to make sure it's audible. So you need to speak up. For those of you who speak quietly, make sure you speak up and they can hear you. But when are counts performed? So before the procedure begins, I mentioned that earlier, that's known as the initial count. Anytime new soft goods are added, so let's say you've saturated 10 lap sponges and you want to add another pack of 5. Well, as you add it, you count them. So they have to be added to the count. Before closure of a body cavity or a hollow organ. So the hollow organ, the one that we really make sure we have an extra count on, is the uterus. So during a C-section, when we close up the uterus, we'll do an additional count because we're closing up a hollow organ. At the start of wound closure, so at the start of skin closure, so as you're closing the wound and then when you close the skin. So usually 3 counts are typically performed, but again, it can be 4 if you're closing a body cavity or a hollow organ. So 3 to 4 counts. anytime there is a permanent change in personnel, so we call this shift relief. So let's say it's 3 o'clock. We have a new nurse and a new scrub coming in. Well, you guys need to do a relief count, all of you together, and the new people coming in should be the one doing the actual count while the scrub and the nurse being relieved stand there and watch, and they assist if something happens. But you definitely always want to do a relief count if there's a permanent change in personnel. We also do counts if we do mesh placement in the abdominal wall. When we're closing the mesh, we're actually closing up the peritoneal cavity when we suture the mesh in, so we would do an additional count for that as well. So just know 2 people always perform the count, and 1 person always has to be in the scrub role. So it will always be the scrub, and then it will probably always be the circulator. Okay. When we count during closures, we always count in a specific order. So it should be counted in this order. You always start with the patient. So what's up on the field? If there's 3 lap sponges on, you start with as you're doing your sponge count, you would say 1, 2, 3 on field. Then you would go to your Mayo stand and how many you have on your Mayo stand. Then you would go to your back table, and then the circulator would count the remaining that have been thrown off the field or discarded. So it's always in that order when you're counting everything. You always, instruments, everything. You always start at the field. So let's say you're counting suture and the surgeon has one in his hand. You would say suture, 1 up. 1, and then you would go to your Mayo stand and count how many are in your sharps box, or if you have any packets up there, then you would work to your back table and so forth. So that's how it is. That's the order of the count procedure, and it's always followed, and that's the way you should always do it. We do use certain devices or certain counting systems, as we like to call them, to assist us with counting. We do have, some facilities have sponge counter bags, and they're these little plastic bags that have pockets in them, and they will separate each sponge and put them down in the pocket. So, and they're suspended on an IV pole, so you can look at visually when you're doing the count, you and the circulator can look at the sponge bag to know how many are in there. And they go in 10. So each bag holds 10 sponges, so you know when it's completely full. And you don't do Raytech and laps in one sponge bag. You separate. So you have sponge bags for all your Raytechs and sponge bags for all your laps, and you separate them. So as you're doing the count, you don't get your sponges mixed up. It talks about electronic technology. Some of you have asked, like, what is the big fat green thing in the sponge? That is a radio frequency device that gets picked up if we wand. Also, some of them have like a scan code or a piece of tape on them that you can scan each Raytech, so you can count it that way and scan them in. So those are other ways to document counts. Obviously, in emergency situations, counts often are waived, but typically at the end of the case, we do an x-ray to make sure that no sponges or any of the soft goods were left in the patient. So obviously, and it would pick up and hopefully see an instrument if one was left behind. And then we document the circulator and scrub. Basically, by doing the counts together, you're the person who's signing the operative report. You're the one that's verifying and stating that counts are correct. And you always verbally let the surgeon know as he's closing that your final count is correct. So they know too that everything is all good and no centennial event has occurred or we need to call x-ray. If you can't find something, you need to speak up. If they're in the middle of closing, you're like, hey, I can't find the lap. So if they've not closed the abdominal cavity, they can reach in and try to find to see if there's another sponge or something left behind. So don't be quiet about it. You always need to be communicating and letting them know that, hey, something's not right, something's off, we're looking for something, our count's not correct. Or vice versa, all counts are good, final count's correct, and then you just keep moving on, okay? So if items are retained or lost, obviously we know that there's complications that can arise. Again, scrubs are accountable for all sponges as they are used. There are some examples of how items can be lost. If procedures are longer than 8 hours and you have multiple staff turnovers during surgery, the team's not done a good job keeping track of their sponges. They don't verbally tell the relief staff that, hey, we have 8 sponges in the abdominal cavity. if your field's cluttered, disorganized. So there's a lots of reasons why things can get retained or lost in the patient. But obviously we know it's an increased risk to the patient. It raised cost. They can get infections. They may have to come back for surgery. They might have to be treated with antibiotics. It can increase stress, not only for the patients, but for the surgical team, especially um, it can make it to where the surgeon doesn't want those people in their room because they're not able to perform correct counts, or they fudge and say their count's correct and it's not, and a sponge gets left in. That has happened before. Inappropriate use of sponges, that would be like using a Raytech on an open belly. We only use Raytex on sponge sticks. You never put a Raytech in an open abdominal cavity unless it's on a sponge stick, because it can be easily lost in a deep cavity. Again, not keeping track of counted items. If there's an improper or no count completed, that can also be an issue. So these are just reasons why items can get lost or retained in a patient. When searching for lost items, again, I mentioned earlier, if the counts are not correct, you obviously need to notify the surgeon right away so they'll stop what they're doing. You definitely look in all the trash and waste receptacles. So this is why we never take trash bags out of the OR in that case until it's completed. They stay in the back corner. You never take trash out of the room. You definitely want to look on the floor really good, examine under the OR tables. If it's a suture needle, we do have magnets that we can roll across the floor to try to pick up suture needles. You definitely always want to make sure you look between the surgeon and the patient. Sometimes it gets stuck down in the drapes. Sometimes it gets stuck under the bed. Definitely can use x-ray to study the patient and look for any retained items that are x-ray detectable. So if the surgeon is often confident that the item has not been left in the wound, and the risk of extended anesthesia does not outweigh the risk of a retained object, often they'll just have x-ray come in and do x-ray, and if there's no proof that it was left in the patient, they'll just assume that the item's lost on the floor or somewhere else, but not in the patient. Obviously, AST and ARN have recommended practices to try to help prevent errors and counts from happening. Obviously, unnecessary activity and distraction should be curtailed during the count. So conversations should be to a minimum. People need to be quiet. Everybody needs to be focusing on the count and what's going on. It doesn't always happen. Sometimes you're trying to count and help hold retractors while the surgeon's closing, because they don't like to wait on us to close. They're very impatient sometimes when it comes to that, because they're just trying to get the patient closed up. But as you practice more and more, it'll get easier, but counts can often be stressful. All your sharps must be contained when you're doing the counts. Your sharps box, they need to be in a specific order. All your radiopaque soft goods should be counted for all procedures. Surgical spun bands should be broken and discarded prior to the count. So you always break those as you're getting ready to count them. You don't break them until you're getting ready to count them, okay? And then items should always be counted as they are added, especially instruments. If you add instruments, you have to count the instruments. So let's say you started with six Kellys. Well, if you need more and they go get another pack of 6, as you're adding them, you have to add 6 more Kellys. So then they'll say +6 on the count sheet, so you'll have a total of 12, okay? One of the things that's very important about this slide and what it notes is that you should never use radiopaque sponges for dressings. Those should never be used. So that's why we have separate dressings that we apply, and you'll start seeing those in the lab this coming week. All counted items need to remain in the OR. You can't leave and take them outside of the room. That's why, again, trash stays in there. Final counts not completed until all the wound sponges are accounted for. So you'll never have a final count if you can't find your sponges. It's always an incomplete account, and it is a centennial event. You never want to cut sponges or radiopaque items. If it's instruments, components that come apart, sometimes those are counted separately. If instruments are broken, they're separated and isolated from the count and to the side. And then again, trash must stay in. So the things that are components that I mentioned that are counted separately are wing nuts, right? The Balfour has the wing nut. Any screws, any pins, things like that are always counted separately, not as one whole piece. Timeout, universal protocol, right? Every hospital does it. So what is a timeout? It is a universal protocol that's done to prevent uh, errors with patient identification, wrong site, wrong surgery. It's performed before the first incision, administration of local to verify other critical information that pertains to the case or the patient. So what do we do as a team? Well, we make sure we have the correct patient, correct site and site, that the agreement of the procedure being done, we all agree upon it, that they are positioned correctly, that we have all the correct implants or any special equipment in the room ready to go, availability of any laboratory or other test results, and often medications as well on the field. We will verify those during the timeout. Like I mentioned, organization is key for your setup. You will become OCD. Basically, as you are setting up, you want to organize things neatly. If you have a suture bag, this is like a little trash bag that is sterile that they tape to the side of the table. You can put your suture down in it. You definitely always want to keep instruments off the patient when they're not in use so the patient doesn't get injured. Clear suction tips, so if they get clogged, you're going to clear them out. You definitely don't want to overmanage. If sponges become soiled, you want to replace them with new ones. So this is actually one of the first things that surgeons look at with new scrubs or students. Like if you can't even put a clean sponge on the field, then they're like, this student can't get through anything. So just be aware of that. If a sponge gets soiled or they throw it off the field, you need to lay a new sponge down immediately. And then you always want to concentrate on the procedure. It's going to be kind of hard for you because you're going to be concentrating on the unfamiliarity of the instruments and things like that at first, but hopefully your preceptor will get you through it. So too much movement and rearranging of instruments also creates distraction. So know where your instruments are, lay them orderly in orderly fashion so you know where they're at all times. Also, the book talks about as instruments are passed back from the field, they should be wiped clean with a damp sponge to prevent blood and body fluids from drying on the surface. If there is a metal stylet, you will use that to push through the cannula of the suction, or a disposable one comes with a plastic one. So just make sure you have a basin of water near the back table to clean instruments during surgery. You definitely don't want to pull sponges out from under instruments or the surgeon's hand. So if they're laying there, don't pull them out. Just leave things there. Just pick up any instruments that are not in use and put them back on the Mayo stand or the back table. And you definitely don't want to reach around behind the surgeon to retrieve instruments because, right, you're sterile, his back or her back is not. So you always want to walk and go up to the field or reach in front of them. Never reach behind them if you're taking instruments off the field. Basically, this is self-explanatory, but again, it's important that you move lights or ensure that the surgeon has adequate lighting. So often you're the one that has to position the lights um, a couple times during the case to make sure that there's adequate lighting so he or she can see. When we talk about sponges, make sure all your sponges have the radiopaque strips in them, and I'll bring those into the lab so you are in the lab or in the classroom tomorrow so you can see the different types of sponges that we use. Again, only mounted 4x4 sponges, which are Raytex, not really 4x4s. I hate that the book calls them 4x4, but only mounted Raytex are to be placed on the field when a body cavity is open belly case. So that is the Raytex on a sponge stick. That's the only time they can be up in the field is if they are mounted on the sponge stick, okay? And so a lot of these sponges, you'll see strings, like your lap sponges have green strings, right, that hang off of them. You'll also see strings on your neuro sponges and your cotton balls. And so these strings keep the sponges from being loose and getting lost. And they also have lines in them that can be radio opaque as well. When managing our sponges, there's different things that we can do to help keep, track of our sponges or manage them. We can use that kick bucket if we want to. I've mentioned that before. You can throw your lap sponges in there or your Raytex. You can't. Sometimes they'll have a throw on the ground for you to toss them on, and your sponges can land on the ground. If they're dissection sponges, they can be placed back into the holder on the sterile field. Again, you always want sponges to be placed where everybody can see them, you and the circulator. There's a designated area for those sponges. So you keep them in the designated area so when you do the count, everybody can visualize them. I typically spread my Ratex out on my field. I haven't taught you guys to do that, but I typically do that. So if I'm tied up and I can't pick them up one by one when we're closing to do the count, the circulator can come over and visualize them and see them. So again, all sponges need to be separated for the counts. During the initial count, you spread them out, and when you're counting at the end, you definitely spread them out too. There's another thing that we haven't talked about yet, but sometimes they will ring out sponges or weigh the sponges to get an accurate reading of blood loss. So sometimes they have to weigh them or ring them out in order to measure if there's been, the patient's had severe blood loss, so we can keep track of the blood loss by looking at the sponges too. So you definitely never want to throw them out, even if all counts are final, until you've verified with the anesthesiologist if it's okay to throw them away, because they're kind of the final say-so person on the estimated blood loss as well as the surgeon. This slide is just some good tips for how to handle and pass instruments. So I would read through it. You obviously want to work at a pace that feels safe and comfortable. When you pass instruments, you want to pass it to the person using the instrument does not have to reposition it. So that means what? Passing it in working order. So pass instruments in their closed position and in working order. You always pass medium weighted instrument firmly. You want to kind of pop it in their hand if it's a clamp. You want to pass delicate instruments lightly, and then a lot of times they use hand signals or hand motions. Again, the pinching, right? That's a forceps, or they'll sometimes do the cutting, the two fingers, and do the cutting like the scissors, like rock, paper, scissors kind of thing. So they'll do that. So a lot of times they use hand gestures, so you'll want to make sure you pay attention to the hand gestures as well. This slide just basically talks about long instrumentation. So basically, as we move down through the layers, you'll start with short, and then as you get deeper and deeper, you'll need to adjust and replace short instruments with long instruments. So if you don't have them in your set, you should have them readily available in the room as you have verified the patient's weight prior to the surgical procedure. If you're using microsurgical instruments, a lot of times that means they're going to be looking through the microscope 99% of the time, so they don't want to look away from the microscope, so you have to place these instruments in their hands so they do not have to take their eyes away from the field. If you notice the surgeon repositioning an instrument each time you pass it, that means you're passing it wrong to them, so you need to adjust your passing technique. And if they are using a microscope to prevent injury, you never want to jar the microscope or the surgeon's hand if you're passing microsurgical instruments. Yes, the infamous neutral zone. So when you're passing sharps, you always have a neutral zone. Everybody's policy could be different, but there's also different manners on what they consider to be the neutral zone. Sharps box on the Mayo, how you hand the sharp back and forth between the personnel. Do you hand it hand in hand? Do you lay it in a basin, a shallow basin? Do you use a small flat tray? Are you using a magnet pad? What is your facility doing to designate their neutral zone? So the neutral zone is just the place where all the sharps are laid to be passed and so forth. So obviously a designated area is established near the surgical wound. It needs to be easily accessible for both the scrub and the surgeon, but you never really want it close to the patient or close to the surgeon. You want it far away so it doesn't prevent injury if they're grabbing stuff off the Mayo, okay? If sharp instruments are exchanged, they are always placed in the neutral zone, whether it's directly into the hands of the team member or you're laying it in something, all right? Again, sometimes the magnetic pad or a shallow basin, this just eliminates hand-to-hand contact to reduce sticks and injuries occurring from sharps. So when we're passing sharps, the scalpel blade, obviously if you've loaded a scalpel with a new blade, you should always announce new blade if you've changed the blade. If it's the incisional blade, if they say hand me the incisional blade, that's the blade they start with to make the initial incision. It's the initial blade. Sometimes as they go through deeper tissues, they use different clean blades because there's more bacteria on the initial blade than there would be down in the wound. If you're passing sharp retractors, you always keep the tips facing downwards. It's kind of like that pinky technique I've showed you. You definitely don't use more than 2 needle sutures on the field at one time unless two surgeons are suturing. So they'll lay the sharp down and they'll tell you sharp down. So you need to kind of recognize where it's at when they're, or listen to where they're saying, hey, sharp down on the field, and you want to pick it up immediately and lay it on the Mayo stand. Okay. We've talked about how to manage surgical specimens a little bit, so we always want to make sure we have correct management of specimens. Obviously, surgical specimens have to be removed from the field and sent to pathology to be studied. Most all tissues or devices removed are sent to pathology because it's protocol. Even if it's not looking for a diagnostic purpose, they'll send it just because it's protocol or policy. They may already even know what's going on. They'll still most of the time send it. If they don't send it, they'll say, I won't send that, or it's junk. Okay, so again, any item removed from the patient has to be registered and submitted for analysis. We're all responsible, especially the scrub, to make sure that we know where our specimens are. It's our duty to care. Responsibility for specimens. If there's a loss of specimen, it can be serious in a diagnosis. Mishaps related to specimens can definitely occur. You can get them improperly labeled or improperly identified, and so it can mix them up. So we always orient them and label them properly when we pass them off. If you throw a specimen in the trash, it can be a centennial event if the trash is already taken down by the time you recognize that you threw the specimen away. If we don't identify cancerous margins properly, we may have left cancer cells in the patient, so that's not good. So again, these are all things that can go wrong. So it's the scrub and circulator and surgeon's response. Specimens are part of the medical record for the patient. So again, preparation for specimen removal begins before surgery. Some pathology departments need a 24-hour notice before we remove it. But when we document specimen, we use patient identifiers, okay? And there's 6 that must be verified. So there's 6 patient identifiers that we must verify. Type of specimen, patient information, analysis needed, date and time, all source information, and a lot of times the surgeon's name and contact number will be on there, as well as the person preparing the specimen. So that list 7 bullets, but the surgeon's name and the name of the person is kind of one bullet together. So those definitely need to be done. There's examples of patient identifiers as well, like what's the age of the patient, what's the gender, what's the healthcare history, what's the organization that's doing it, preparing the specimen, and then what's the preoperative diagnosis. Also, what type of specimen, as far as treating it or when we're sending it, do we do. So there's types of different tissue specimens that we get together when we're sending them. Obviously, we have biopsies, we have frozen, we have saline, we have formalin. We can go over those too as well here on the next slide. So when we look at types of tissues, the first one that we talk about is a frozen. So we're doing tissue biopsy for frozen, which means that this is not put in any solution. It's dry when it's sent down. So PASS needs it to be dry, no solution to be on it. If it's frozen, once they do the diagnostics on it, they will send it to histology and then put it in formalin. If they send a specimen for permanent, they say, if the circulator asks, is this for permanent? That means it's going to go in formalin, okay? If it's frozen, it will not go in any type of fluid or solution when it's being sent to the lab. So what types of specimens do? We do tissue biopsies, we do excisional biopsies, we do incisional biopsies, fine needle aspirations, core needle aspirations, where they go in and take a core biopsy. A needle goes in like the liver and takes a core biopsy. If it's a frozen section, you call pathology immediately, and then it requires immediate analysis. A lot of times we don't even close up the wound until pathology comes back and verifies that we've removed all the tumor and we've marked it correctly. So some other specimen types, obviously it talks about stones. If you get stones like kidney stones, urinary tract stones, gallbladder stones, those obviously have to be retrieved and sent. If we do bulk tissue, this is organs or partial organs that are received, like a big bulk tumor, some type of tissue that we're sending. Amputated limb, obviously, they'll pass the limb to the scrub, and the scrub will pass it off to the field, to the circulator, and usually, however it's sent at your facility, it's already ready to go. That's part of like the pre-op planning, is you get the bags ready as how you're going to send the limb to pathology. Cells, cytology washings, these are done. This is like a collection of epithelial cells to rule out carcinoma. So a lot of times they'll do brush biopsies and so forth. And then they'll send the brush down, and then they'll take that brush and put it on cytology slides and look at it underneath a microscope. If we do products of conception, so this is fetal or embryonic tissue, sometimes we have to send that. It's called a D&C, a suction D&C. A lot of times when we're sucking up the contents, it will be filtered through what we call a Lukens or Likens trap. And so the contents will get trapped in that actual like mesh trap and not get sucked into the suction container. All foreign bodies or previous medical devices or any things that are left in, we definitely send those. Weapons, bullets, anything that kids have stuck in their ears or their nose, that happens quite often. Any food that's been swallowed and stuck in the trachea or things like that. If there's the medical devices I mentioned would be like implants. If we go in and there's been a failure of an implant or some type of medical device we've implanted and we remove that, we would obviously send that as well. So those are all foreign bodies. Cultures, we've talked about cultures in chapter 8, so I'm not going to go over that again, but we do cultures. And then obviously we send body fluids as well often. We will suck or aspirate body fluids and send those down for analysis as well. This is just a repeat of what we've been talking about. Obviously, when you're receiving specimens from the field, you always want to place it in the appropriate container, document the time and origin. You definitely, you look at how tissues have to be preserved. If it's frozen, like we previously discussed, if it's not, and it's not going in a dry container, we can put it on Telfo with saline and put it down in formalin. What is it that we're sending? So there's other tissues that may not be preserved for formalin, but so they're not frozen, but we still transport them in a dry container. So that would be like a cone biopsy of the cervix, lymph nodes, or something that we send dry, not for frozen, but just because of the types of tests we're running and so forth. Usually, again, advance notice is required by pathology for the following types of biopsies, not only if it's frozen section, but kidney biopsies or muscle biopsies. Those two, they notify pathology in advance that we're going to be sending those kinds of specimens down. This slide again just talks about if we're transporting, if we have to be the ones to take the specimen down to pathology, that again, you must identify the patient with 2 distinct identifiers to ensure that this is actually the specimen for the correct person. And those identifications again are patient identification, what the type of tissue is, the origin, the diagnosis, if there's special markings like suture markings in it, if it's left lateral, short, superior, like we've talked about, the date and the time of the surgery. We also want to make sure it's in the right container and labeled before we send it down or transport it. When talking about wounds, basically this is just some things that fall under wound closure. Obviously, before we close a wound, a lot of times we'll irrigate it out with warm saline before we close it. Again, before closure, counts are always completed before complete closure. All excess instruments are removed and organized quickly for the counts during the wound closure process. At this point, once you've done your counts and counted your soft goods, your dressing material can now be opened or distributed to the field, or if it's already on the field and you've hidden it away, you can pull it out. So definitely never bring dressing material to the field until after the deep wound is closed. You can bring it when you're closing the superficial part of the wound, okay? It's just important that you don't do that. Once the wound is clean and closed, then we will apply dressings. Again, dressings are never brought to the Mayo or to the field until the superficial wound layers have been closed and counts are completed. You're required as a scrub to remain sterile with suction connected and working until the patient has left the operating room after the dressings are applied. It tells you that, but that's not really how it always works. But, just be aware that, it's important that you keep all your stuff sterile and pushed back. If you're the one applying the dressings and you get contaminated, then you can just change your top gloves and stand back if you need to be. So, again, you'll see all this when you get to the clinical side and kind of see the sequence of how things works. So if you have any questions, we can discuss them tomorrow morning in class prior to the test, or feel free to email me.